Doctors, we are live. You can start the session.
Sure.
So let Aditi, are you sharing the screen first?
Yeah. So I'll just stop it. Yeah, no problem. You can go.
Yeah. We are live?
Yeah.
Yes.
Okay. A very good evening, everyone. So we all welcome you on behalf of YOSI Cornea Focus Group, led by Dr. Karan Bhatia and me, Dr. Aiti Khozasvidar. So this is our first session, a master class by none other than Dr. Rajesh Fogla, sir. And over to Dr. Karan Bhatia for the introduction.
So thank you first to Dr. Rajesh Fogla, sir. Before that, I'd like to introduce the members of the YOSI Cornea Focus Group. We have Dr. Aditi, as she said, she and me are leading the group, along with Dr. Aditya Pradhan, Dr. Gundan Budhiraja, Dr. Kavya Chandran, Dr. Kunal Mandlik, Dr. M. Nishant, Dr. Nikunj Tank, Dr. Rushad Shroff, Dr. Tushar Grover, and Dr. Sunandini Bose. So let's go to the master himself. So introducing Dr. Rajesh Fogla is not an easy task. He has been my teacher and the teacher of teachers. He has trained more than 500 cornea specialists. He does also a course, which is a very wonderful course on various types of corneal procedures. He is a gold medalist in MBBS, a DNB, FRCS, FRC Ophthal, FACS, and MED, more than 25 years of surgical and clinical experience. Also worked at Shankar Netralaya, and now he's currently for many years at Apollo Hospitals, Banjara Hills, Hyderabad, where he's the director and a senior consultant. He is a pioneer in advanced keratoplasty, all types, whatever you think of it, he's done there. He's an innovator and educator, and also makes a lot of designs and innovates a lot of instruments. A particular thing about sir is, the topic is that we're talking about is the art of suturing, but it is what I would say is, how does sir get the optimum results, 6/6, 6/9, 6/12, or minimum astigmatism? How does he control the suturing? How does he manage those results? This is what we are here to learn. uh, uh, Over to you, sir, and a big thank you for blessing young ophthalmologists with your teaching and being a part of the first episode of the YOSI Cornea Focus Group.
Thank you, Karan. Thank you for choosing me to be the first speaker of your YOSI focus group. Hello, everyone. And it's a pleasure to be here this evening. And I will try and share some tips from my clinical practice on how to optimally do suturing in corneal transplantation surgery. It's a very basic topic. And yeah, so my slides are visible. You can see my slides, Karan?
Yes, doctor.
Yes, sir.
I have no
So we can see the slides, yeah.
disclose. Now, when you talk about suturing, I think for corneal transplantation, suturing is the most vital step, because a proper suturing would ensure a proper wound healing. It would also maintain the graft clarity and give optimal refractive and visual outcome. As you see in the clinical photograph, this patient has undergone a corneal transplantation surgery 14 years back, and after suture removal, you can barely see the corneal scar at the graft-verse junction, and on the anterior segment OCT, the corneal curvature looks very good and very good apposition of both the anterior and the posterior aspect of the graft. So this is what we should strive to achieve when we are doing a corneal transplantation surgery. So what are the basic principles of suturing in corneal transplant? One, we want to oppose the wound edges in the normal anatomical position. When you do keratoplasty, ideally we try to oppose both the anterior and posterior, but yes, from the surface healing aspect, sometimes the anterior apposition is more critical. It should aid the natural healing process and minimize the scar formation at the graft-verse junction. At the same time, the wound should be secure to prevent any wound leak and thereby reduce the risk of infection. and the wound strength should be strong enough not to give away. And it should not induce significant astigmatism because you have a circular wound and you place suture all around. So the tension has to be optimal all around the wound. Now, when we talk about doing suturing and in corneal transplantation, there are some essential instruments that you need to have. You need to have corneal calipers. You need to have markers like the 8, 12, or 16 marker that gives you alignment mark and the starting point for the sutures. You have the surgical marking pen. In terms of the sutures that we use, commonly we use the 10-0 nylon, although Mercilin has been described in literature, but still not very popular. Nylon is elastic, easy to handle. The only disadvantage is over a period of 1 to 2 years, the nylon starts degrading and then it starts breaking. Mercilin does not degrade, but the problem is it's a monofilament and it's slightly difficult to handle, and it may require readjustment over a period of time. You need to have a needle holder. You need the colibri or the pierce skin to hold the corneal tissue. You can use the LIMS forceps or the Pollack forceps. We'll show the same. You see the Pollack forceps is a double-ended forceps. That's very critical when you take the first suture when you are doing a penetrating keratoplasty. For suture tying, you need the non-tooth, both straight and angled tying forceps, and you also need something to look at the reflex on the cornea, like an intraoperative keratometer, like the Maloney's intraoperative keratometer, to understand whether the tension is symmetric all around the graft. In terms of sizing of the graft, for normal indications, we tend to oversize our donor by 0.25 to 0.5 millimeter. And for the recipient bed, instead of using regular handheld Trifine, if you use the vacuum Trifine like the Hesper Baron, you will get better configuration of the wound and a symmetric cut, which is much more vertical. Or if you have access to femtosecond laser, you can make shaped incision, which pretty much helps you fit like what you see with the carpenter, when they are aligning the pieces together, they fit together like a jigsaw puzzle. So that's what we should aim for. The donor button can also be punched from the endothelial side using a endothelial punch, either the vacuum or the non-vacuum. And once you have punched it, keep it hydrated and in the BSS to protect the endothelium. So when you're suturing your graft, you can use a wide variety of techniques. You can use single interrupted sutures. You can use combined interrupted and continuous suture. You can use single continuous suture where you put initial 4 cardinal suture and then maybe a 24 bite running suture, and the 4 cardinals are removed at the end. Or you can use a double running suture where you can use a 10-0 and a 9-0. 10-0 and 11-0 to place the double running suture, usually 12 in 12. These are all various combinations that have been described and tried in literature. There are some advantages and disadvantages of each of them. Single interrupted sutures can vary anywhere from 10, 12 to 24, depending on the graft diameter. If you're doing in a pediatric case, if you put a 6.5 or 7, sometimes 10 to 12 sutures are more than sufficient. But if you're doing a 9, 9.5 or a 10 millimeter graft, because of the increased circumference, you may require maybe 24 or more sutures to ensure that the tension is, the wound is secure all around. The advantage of interrupted sutures are that they are easy to replace, and during surgery, if you make a mistake and you don't put the sutures the right depth or the right bites on either on the host or donor, you can easily replace them. Or if you make a suture which is slightly tighter or something which is not optimal tension, you can always go back and revise. Post-operatively also, a selective suture removal can be performed guided by the topography to manage astigmatism. A combined interrupted and continuous kind of takes the benefit both of the interrupted and the continuous sutures. The advantage of continuous suture is that it allows adjustment of suture intraoperatively to minimize the astigmatism. You can do that with the interrupted sutures as well, but then you have to, replace and reapply a lot of intraocular sutures to get the optimal circular shape. Whereas in the continuous suture, you can just, adjust the suture around the circumference, and by adjusting the tension, you can get the nice round reflex, and that can help minimize astigmatism. This manipulation can be done in the early postoperative period as well, if required based on the corneal topography. You can put the running suture with the taking the bites radial, or you can put them in a angulated like an isosceles triangle, which is called a no-torque placement, which you will see in the videos that I show you next. And a combination of 10 and 11-0 nylon can be used. And usually you start off with the 10-0 nylon, and this, which is usually at 90% depth. And then when you go on with the 11-0 suture, that can be placed a little superficial at 50 to 60% depth. And usually it's done like that because you don't want the first suture to accidentally cut the second suture to accidentally cut the first suture. So this is where the three main techniques of suturing that we use. Now, when you're handling the suture, it's important that, even when you take your throws on the angled tying forceps, in the first image that you see, make sure that you take it in a very symmetric fashion. Don't take it in a haphazard way that the suture. What happens is this does not allow a proper knot formation. You get entanglement, which is not great. And the second is that when you take your bites in the cornea, usually 1 to 1.3 millimeter on either side, but try to take a bite that goes close to the decimals, like 90-95% depth. Because if you take a superficial bite, it may oppose on the surface, but you get an internal wound gape, and the wound is always, with the microdehiscence, the wound always remains weaker. And this post-suture removal has a greater tendency for this part of the wound to bulge forward and induce more astigmatism. And if you take uneven bites on either side, that means you take a deeper bite on the donor and a superficial bite on the host, that will lead to overriding. That can also induce astigmatism. It can also lead to excessive scarring at the graft source junction. Sometimes you get a lot of epithelial hyperplasia because of this overriding, and you have unwanted appearance of the graft as well. Now, when you start off, you take cardinal sutures. These cardinal sutures are placed at starting at 12, then 6, 3, and 9, equal bite, width, and depth. And you also check for the centration. The depth is usually 90% of the corneal thickness. Now, one problem that you face is that when you do this suturing, the 12 and 6 o'clock sutures are reasonably easy to apply. But when you go on to the 3 and 9, because of the angulation, you find that applying those 3 and 9 sutures can be a bit more challenging. And sometimes they don't end up being perpendicular to the graft or junction. So one way to overcome that is that the initial suture, you need not apply at 12. You can always go little off. That means you can apply it at 10 o'clock and the other one at 4. Thereby, what happens, your next suture is at 2 and 8. So thereby, you still get your square or the diamond configuration, but it's easier to apply the way you hold your needle holder. It's easier. The other solution to that would be that you apply the first 12 and 6 seated superiorly, and then you can shift to the temporal position and then apply the 3 and 9, which is virtually like applying the 12 and 6. So thereby, you get very nice placement of the first 4 cardinal sutures. And I like keeping the surface a little dry because of the tension from the sutures. I can see whether I'm excessively tightening the suture when I'm applying my knots. So as we mentioned, the entry and exit is 1 to 1.2 millimeter from the wound edge. It should follow the corneal curvature. So basically, you look at your needle. You hold your needle 1/3 from the distal tip, between 1/3 and 2/3. That's where I hold with the needle holder. And I allow once the needle enters the cornea, it should follow the natural curve of the needle, So you don't really, so it should be a very nice curve which follows the corneal curvature. And when you tie the knot, we will come on to that. You can commonly, we use the initial first throw is 3 throws on the tying forceps, followed by the first knot is called the approximation knot. So what is the purpose of the first knot, whether it's 3-throw or 2-throw? It is basically to approximate the edges, and that decides how tight your graft-oss junction is going to be. The remaining 1-1 that you apply, which are usually applied in the opposite direction to the first throw, that is basically to lock the approximation knot that you placed. And you don't need to add more knot. You don't have to go 3-1-1-1, add some more, thinking that that's going to make your wound more secure. It does not add any greater strength to your wound, but makes the knot very bulky, and burying that knot can become a little bit more problematic. A lot of people in the West like to use the slip knot, which is like a single throw. So the first 2 single throws are in the same direction, and that allows you to adjust the tension. And once you feel that the tension is optimal, then you can put the last throw in the opposite direction, and that kind of locks the knot. The only problem in this knot is that the first knot, when you put just with a single throw, it's sometimes difficult to keep, it kind of keeps slipping off, and then you put again the same. So if you're not very careful, sometimes the second throw can lock the knot, and then you're not able to slide it, and you have to go back and revise. Now, these knots, whether you bury on the host or the donor side, there are some plus points on either. Burying on the recipient side gives you the advantage that when you remove the suture and your knot is buried, but you pull during suture removal, you pull the knot out, there is a less chance of the stress on the donor is less chance of the graft-oss junction opening up, especially if your knot is stuck in the wound. But if you have a big knot on the peripheral side, it can induce inflammation. It can bring in blood vessels to the graft-oss junction. So that's why it's usually recommended that you try and bury it on the donor side, which is far away from the limbus. So there's less chance of the graft-oss junction getting vascularized. Now let's look at suturing. If you see, so this is with the Polak forceps being held. You made the first pass 1.2 millimeter on the, it should go about 90%. The video says 80%. You take the 3-throw, and then you can see that you're holding the suture, you make the pass, and then in the reverse direction. Always remember that when you're tightening the suture, it should move in the opposite direction, or it can be 90% to the primary suture that you've placed. So thereby, you don't over tighten the suture. If you are not very careful with your the way you're holding the suture, the knot forms, and then it can slip, and it can create further tightening of the original wound. Watch in this video as well. I'm holding the needle at 2/3, 1/3 junction. That's the Polak forceps. Again, it's going 1.2 millimeter, going 90% of the depth, coming out very close to the decimals. Again, going to the base of the wound, coming out again 1.2 millimeter on the either side. 3-throw, hold the suture, pull it towards you. The second throw, pull it away from you. The third throw, again, you can see that. That's it. The video is running at twice the speed. I don't suture that fast. So that's how the knot, and you can see that if you keep the surface dry, you can see if you're inducing too many folds. If you're inducing too many folds radiating from the suture, that tells you that your suture is excessively tight. And so you should tighten the suture just that it approximates the wound. And remember that if you are suturing in an eye which is slightly softer, then when you form the chamber, these sutures will become more tight. This is a video of the slip knot.
Pull the suture.
So you can see that that's the first throw. Then you have this in the same direction, you take the second throw. And now you see that you can tighten this. If you pull, it will become tight. And then if you feel it's excessively tight, you can always relax. You can, manipulate the suture to loosen it. And once you feel that it's in this, now you can see he's loosening the suture. So that's the advantage of the slip knot, that you can go back and you can adjust the tension. And once you feel it's the optimal tension, you can go in the reverse direction and apply the knot, and that kind of locks it in place. So you see that. So now it's optimal tension. You go in the reverse. and then you lock it. So now it's not going to slip. So this is again something that can be done. If you like using it, you can practice in the wet lab using the slip knot, and you can use it for your surgery, and that can help you better adjust your the suture tension when you're putting multiple sutures. Now, yes, you can use a mark on the cornea when prior to starting surgery. So this helps you put in the graft, and then you along these marks, you can ensure that you place all your sutures symmetrically. You can get an 8, 12, or a 16, and ensure. The only advice I have to give is that before you apply the mark, dry the surface, otherwise the ink tends to get smudged. If there is any loose epithelium, you can even debride the loose epithelium and then apply the mark. Before you apply the mark, just apply the marker without the ink, and just to see, create an impression and be sure where exactly you want it. Because if you apply the ink and then apply the marker and you realize that it's not well centered, then again to reapply another mark may become difficult. And always wash off the excess ink. The problem is getting good marking pens. I usually like to use the marking pens that come with the toric IOLs. They are quite good. They are the viscose skin markers, and they are pretty good. Don't apply excessive ink as well, because that tends to smudge the cornea. And then sometimes it makes it a little bit difficult to visualize when you're suturing as well. So as a routine, my suturing is quite symmetrical. I go by a divide and conquer technique, where I place the sutures, and the next, after the 4 sutures, it just, the remaining sutures are always in between the first 2 sutures. So thereby the sutures are quite symmetrical. But when you're starting off, no harm using one of these devices to mark the cornea. You will see in this video that we have marked the center of the cornea, then coming with this is the 8 marker. And you look at the centration mark and then apply on a dry corneal surface. You get those 8 marks, and then you can do your trephination. And these 8 marks acts as guide when you are applying your sutures. In terms of trephination, yes, as I mentioned, that you would like to have a very symmetrical edge of the host bed and the donor as well, because nothing like having a perfectly aligned donor and recipient. That's the beauty of using the femtosecond laser. When we use the femtosecond laser, especially shaped incision, we find that the donor and the host really fit very well. But when you are doing manual trephination, if you use a handheld trefine, you have to be very careful, because the pressure with that trefine is not symmetrical. So you can tend to cut deeper at one edge than the other. So the vacuum trefines are very good. And I like using both the Catena and the Moria trefines, and even the ones from Surgistar. In India, you get from Madhu Instruments as well. So they ensure that you get nice centration, and the cut is very symmetric all around, and makes it much more easier when you have a well-centered cut on the cornea. Now here you see that we have the marks. I apply the Hesburgh-Barrett vacuum trefine on the cornea. The crosshair in the center allows for centration. And once you're sure that your trefine is in the right position, you can go ahead and move the trefine. I don't go through and through, because I don't want to damage the iris. So we go about 6, 7 quarter turns. And once you remove it, you see that you get a very nice cut, which is circular and symmetric in depth all around. In terms of suturing, now let's look at suturing, what we discussed earlier. As I mentioned, hold the needle between 1/3, 2/3. Don't hold right at the tip, slightly away from the tip. Take good bites, 1 to 1.2 millimeter on either side. Go 90% depth, and then ensure that you take a 3, 1, 1. And no excessive tightening, just approximate the wound. And now you see that this is the cardinal suture being placed. So we hold at the other end with a 0.12 colibri or a lynx forceps. Get your suture out on either side. This is again a 3 throw. approximate, ensure that the distribution is symmetrical on either side. So this is good. This is important. The second suture is very vital. So you don't see any gaping on either side. Then come back, take a bite at the 3 and 9. So the marks you can see are helping in terms of positioning the suture. Again, 3 throw, approximate, and then reverse, and then again a forward throw, a single. That's it. That's a 3-1-1. You can cut with the vanas or cut with a slit knife or a sharp knife. That's perfectly fine. That's the so the 4 cardinal sutures are important. Whether you do single interrupted sutures or you do a continuous, it's important that the first 4 sutures should be placed properly. You can see the nice diamond configuration or the square configuration, and there should not be any excessive tightening on either side. This is after we place the remaining 4 sutures. I'm going to put a running suture, so I'm burying the knots from the, now in terms of the running suture, you can see that I'm going to put angulated. Let me try and see if I can. So you see here that this suture is not coming, radial means it should have come like that, but it's coming angulated like that and is going to go back like that. So it forms an isosceles triangle. That means this angulation and this angulation is the same. So you go like that. So the advantage of this is that later on when I'm tightening the suture, there is no distortion of the interrupted suture. That means the graft doesn't talk. It doesn't turn around as the sutures are tightened. Whereas if you do a radial suture, at the end of it, when you tighten your continuous suture, because the radial sutures will induce a torque, which can be clockwise or an anti-clockwise direction, depending on how you're suturing. The radial sutures, instead of the interrupted sutures, instead of remaining radial, can become tilted a bit, which may influence your overall induction of astigmatism. So you will see that we go ahead, and these need not be 90%. The running suture usually even 60 to 70% depth is good enough. And compared to interrupted suture, running suture has a better apposition of the donor and the host. This is running at 4 times the speed, so just to give a clarification. So you can see that you can symmetrically go. Just you have to be careful that you don't get your sutures entangled, and take your time, take the bites. If you want, you can even mark the points where you intend placing your sutures using a Sinskey hook, and just put dot marks on both the donor and the host where the entry and exit should be, so that you can visualize where your needle points are going to be, so that when you're placing the suture, you exactly know where you're going to go and come out. Without that, if you try to do it, depending on how you are holding your needle holder, you can have in certain quadrants, the suture looks very nice, but especially between 6 o'clock and 10 o'clock, that part for a right-handed surgeon, that part placing the sutures are not really great, and you find that your angulation tends to change, and then the suturing does not look very symmetric. In terms of tightening the suture, what you saw me do there, you can see that when I tighten the suture, this is where I'm going to tie the knot. So I go at the opposite end, and I tighten the suture from there, both anti-clockwise and clockwise. So I don't go in a circumferential fashion. I start at 6 and I tighten towards the place where we are going to tie the knot. That kind of ensures that there is no rotation of the graft. Otherwise, if you go only in one circular direction, sometimes the graft can rotate a bit. Although if you are putting no torque suture like what I have put here, the graft should not rotate. And even before you tighten your final suture, it's always important that you normalize the eye pressure. That means I would inject some BSS into the anterior chamber, keep the chamber well formed, neither too tight nor too soft. And then I would put the final tension. Because if the eye is soft and you tighten the suture, your corneas can become excessive flattening, and then you find that your patient has a hyperopic shift in the post-op period. once you're sure that everything is good, then you can, and this is where we use our keratometer. You can see that it's looking still fairly round. There was a little bit of a vertical oval. That means my horizontal sutures were a little tight. So I kind of pull the sutures from the vertical, from 6 and 12 towards the 3 and 9, kind of trying to loosen the tension in the horizontal axis. And once we have done that, now we go back, and if we check again the reflex, you find that the reflex looks a little bit more circular, although there's maybe a excessively loosened. So again, we go back. So you can do that till you get a very nice circular reflex, and you're happy with that. And that's pretty much should be the end. You don't have to keep if you keep manipulating, you don't have to get a perfect circle. But I think something close to that. Now, if you see, this is the end. I'm very happy with that. And yeah, still not. Yeah, this looks good. Yeah. So this is the end point so that's the advantage of using a Maloney's intraoperative keratometer, that you can look at the reflex, adjust your tension. Although these tension, the tension can change as the graft dehydrates and settles down, but at least we should make an attempt at the end of surgery to try and leave behind a nice round reflex to the extent possible. That was what I showed you, was a DALC suturing. Now let's look at PKP. The difference in PKP is that you have an open globe. Now, in an open globe, if it's a phakic eye, maybe sometimes you need not even apply your Fleringer ring, but make sure that your speculum is not overtly tight and there is no significant upthrust. But if you're operating on a deep set eye or a vitrectomized eye with a secondary IOL or a pediatric eye, so in those kind of scenarios, it's always helpful to put a Fleringer ring so that the globe does not collapse. Because in those situations, when you remove the post cornea, the wound tends to become a little bit oval. It doesn't, depending on the speculum that you've applied, it doesn't retain the circular shape as what you see in graft. And there, I think the mark that you put, the 8 or 12 or 16 mark or reference marks that you put, becomes very important, because you can easily identify even if the wound looks a little bit distorted. Otherwise, sometimes once you suture your cardinal sutures and then you form the chamber, you have to again go back and revise some of the sutures. Now you see that we have these are the 4 marks that I have put where I'm going to apply my Trifine. I like putting that. That's an 8 millimeter Trifine. So I'm using an 8 on the host and an 8.5 on the donor. I like making a paracentesis because instead of accessing the anterior chamber through the graft-verse junction, having a peripheral paracentesis is always good whenever you want to access the anterior chamber to inject either air, viscoelastic, or fluid. And when you're trifining, before you do your complete removal, you always put in some viscoelastic into the anterior chamber. Now, before I open up the graft, this is a vacuum donor punch from Catena. This is the new one, which has the mark also. So that kind of shows you where you're exactly going to punch. So that's very useful to have that. I like these endothelial punch using an 8.5, 0.5 millimeter larger. And I can always see whether the punch is complete or not if I rotate the scleral rim outside the area of the punch. That ensures that my punch is complete. You gently remove, and you will see that you get very nice vertical edges. And this kind of, you apply some viscoelastic on the endothelium to protect, and then you can place the, using a patent spatula, you can put the donor back into the storage solution and then go back now to the surgery. Now remember that now my chamber is also having the viscoelastic that avoids any sudden decompression. It's important to have very good corneoscleral scissors as well. Try to keep your scissors vertical so that you can get nice, vertical cuts. There is no shelving or sloping. Although sometimes people like to make, especially if they have already done a 90% depth trifinition, the peripheral edge, they may want to leave a small ledge, which kind of acts like a support when you put in your donor graft. But that should not be too, the ledge should not be too bulky or too big, because that affects your apposition of the graft to a junction and can induce astigmatism as well. Now you see that I remove the post cornea, and then I realize there is a ledge. I go back with the Vannas and I trim out that excess ledge where I thought that it was looking a little bit more prominent. Now put in some viscoelastic before you put in your donor graft to protect the endothelium, and then we apply the donor graft. Now you'll see that the first suture is the most important. Sometimes you can rotate the graft to ensure, to see which is the best approximation. Here you see I'm using a lymph forceps, which is a tooth one. Get a good grip, go in front, just in front of the the tip of the forceps, and then pass your needle. That's 90%. Again, I put it on the host side, and there is enough viscoelastic protecting the endothelium, so the graft just tend to slide a little bit on one side or the other, but that's just on the bed of viscoelastic. Again, you will see that we go for a 3, and you just approximate, don't tighten excessively, and then the reverse, moving the time forceps in either 90 degrees to the wound or in the opposite direction. I just fold it the opposite, and if I stretch it, I can see, because you see a fold that kind of bisects the cornea, and it should be symmetrical on either side. So you again go 90%. So before you apply on the cornea, you kind of just apply the needle and see whether your graft is going is symmetrical or not. Again, a reverse 3 throw, then the single in the opposite direction, and then the final reverse. Again, you can see that now it's going to move, 90 degrees. So that's, again, applying the cardinal sutures. And once I've done with the 4 sutures, now at this point, instead of putting in viscoelastic, what I like to do is, I always like to put in an air bubble in the anterior chamber. The air bubble, it's kind of helps maintain the contour of the cornea better, because you can see how much of air you are injecting in the anterior chamber. But when you use viscoelastic, there is no end point to the amount of viscoelastic you are injecting. So you can sometimes overfill, and that viscoelastic kind of comes out on the surface, and that also interferes with your suturing. It kind of gets onto your time forceps, the suture slips. And now the remaining sutures that I'm going to put here, you have to try and see to it that your air bubble does not escape. So if you are not manipulating the tissue too much, the air bubble should remain in the anterior chamber. So you can see that we take bites in the opposite quadrants, again going 90% depth thickness and about 1.2 to 1.3 millimeters. So similarly, apply the first. Yeah. So that looks, so now you can see that I'm drying the surface. I can see on the dry surface that the tension in the sutures look very symmetrical. At this point of time, if you feel that the sutures are not symmetrical, you still have the option of adjusting that. Because if I'm going to use a running suture now, but my intracted sutures are asymmetrical, the running suture will not be able to give me a very good, reflex at the end, because the intracted sutures are not symmetrical. So at times, sometimes we use the keratometer, even at that stage, at this stage, before we put the running suture, just to get an idea that the overall distribution of the sutures are quite symmetrical. And the running suture is the same as what you saw in the dark. But like I say, that you can see that throughout this surgery, I'm not replacing that air bubble. That means my overall manipulation of the graft-host junction is not too much. And I think if you're going to improve your surgical skill, you should try and aim for that, to try and see to it that but it's okay, even if the air bubble comes out, sometimes you can always go back and replace. And I like putting an air bubble because I don't put in too much of viscoelastic in the anterior chamber. At the end of suturing, I don't have to spend time trying to wash out all the viscoelastic. And because we don't use too much of viscoelastic in the anterior chamber, the post-operative IOP spike is also less. So you will see that we will finish our suturing in the symmetrical manner. And before I tighten the suture, I remove the air bubble, and then I'm tightening the suture. Similarly, I'm going from, I started at the opposite end, did the anti-clockwise. Now I'm doing the clockwise tightening from 6 to the point where 11, where I've finished. Once I'm happy with that, I've taken off all the slack. If there is any doubt, I can go back and do that the second time. But always remember to keep holding on to the suture, because otherwise you don't get the slack coming out. Once I'm sure that the sutures are optimally tight, I go back and put in the 3-1-1 to close the. And remember, when you're suturing, that if you have any bleeding on the surface, always keep your surface neat and clean. That means if there is any, sometimes when you have corneas which have peripheral vascularization, or even when you take interrupted sutures, tends to bleed. But if you continue to suture with all that bleeding happening, you can put bits and pieces of Merocell sponge in the area of bleeding. That kind of ensures that the blood does not interfere with your visualization or the suturing process. Now you can see that again, I'm going to use the keratometer and look at the reflex. And even the air bubble in the anterior chamber also gives you a clue regarding whether your graft tension is optimal. If you have excessive astigmatism in one quadrant, the air bubble in the anterior chamber will also take. This is the post-op day 1. You can see that the graft looks very good, very quiet eye. Astigmatism management, we mentioned about the use of keratoscopy, and there is a new device developed by Remedio, which is a phone-based topography. So maybe if you can get your hands onto that, even intraoperatively, you can take a photograph with that phone and try to look at the topography. You have microscope-based illuminating light, circular light, that also maybe I'll show you in the next slide. So astigmatism management, also the selective suture removal post-op, or if your sutures are loose, you can always go back and resuture, or if you have a running suture, you can adjust the tension, and this can be based on the topography and the refraction that you do. How soon you can start removing suture? I think 6 to 8 weeks is the time when you can look at adjusting the suture by removing. If you have 16 sutures, maybe one suture, if you feel is tight, you can remove. But I believe that in the first 3 months, if you remove sutures, I always go back and if I have a tighter suture, I remove it. I go back and replace the suture which is of optimal tension. Or if I feel that any suture has become loose, I remove that and go back and put another one. Now you have the Melonis intraoperative handheld, what you saw me use in the video, but you have these devices, the ring of lights that can be attached to your microscope, and they continuously give you the reflex. You can switch them on. And so even while you are suturing, you can look at that and optimize the tension in your sutures. Now, as we mentioned that when you see a reflex, your reflex is not round. So how do you, so always remember the short axis is the steep axis and the long axis is the loose axis. So that means if you see an oval, go back to your sutures and see. So if you first of all normalize the IOP. With the normal IOP, if you see a reflex like this, go and see in the long axis. If you feel, just go with your tying forceps, hold the suture and try to move it. If it looks very loose, that's the culprit. So you need to go back and replace. But if you feel that those sutures are optimal tension, then it is likely that the short axis, the stitches which are on the short axis are tight. So then you need to remove those sutures and replace them with lesser tension so that the reflex becomes circular. If you have a running suture and you see this kind of a reflex, then in the short axis, you need to move sutures from the long axis. That means where it is loose, from that axis, you start pulling the suture towards the short axis so that you can loosen the short axis, and the long axis you can tighten and thereby get the reflex to become circular. as we mentioned that, yes, you start suture removal 3 to 6 months, use topography, refraction for timing. If my patient is seeing very well, although some surgeons like to remove all sutures after a year or between 12 to 18 months, if my patient is under my follow-up and can come back to me at a short notice and has very good refraction, I try to keep the sutures in as long as possible. But yes, if your patient is not under your follow-up, going away, then it's important that after a year, if you feel the wound looks reasonably healed, you can remove the sutures. So all the suture-related complication of broken sutures, rejection, vascularization, or infection, these can be minimized. So the key takeaways of suturing is that it's a critical step for successful outcome in corneal transplantation surgery. Get the right instrumentation. That's very important because if you don't have the right tools, sometimes placing sutures can be difficult. If your tying forceps are not great, they are slipping, then you cannot optimize the tension. Or if you don't have a tooth forceps that hold the cornea properly, it may be difficult to take the optimal bite. Or if you're using a suture material or the needle, which is not spatulated or sharp enough, then sometimes passing the needle through the cornea can be a little bit more challenging. So you should prioritize equal depth, tension, and centration. It can be minimized by using optimal surgical suturing techniques and use of the keratoscope. And whether you use interrupted, continuous, or a combination of both, this can be based on the indication. Sometimes when I do very large diameter graft or repeat corneal transplantation or pediatric patients or eyes with peripheral vascularization or with OSD, I always prefer to put interrupted sutures. So continuous sutures you have to do only when you feel that these sutures are not likely to become loose in the immediate post-operative period. Because if they do become loose or they cheese wire, then it becomes a big problem because you cannot do any selective suture removal. You have to take out all the running suture and then go back and again place interrupted sutures. So I think this is in short about suturing in corneal transplantation surgery. I'll be happy to take up questions and we can discuss, and I can stress on any points that we have put in this presentation. Thank you. Thank you for your patient hearing.
Thank you so much, sir, for the great talk. And we have a lot of questions. Karan, will you start the Q&A?
Mute.
So you were saying something?
So can you please repeat?
Yeah. No, it's fine. My MacBook was on mute. No problem. Tell me.
Okay. So let's take up questions from the Zoom. In the meanwhile, Prasanna, are you there? You can check up. Prasanna is our joint secretary, sir, and Diva Kant is our president. He had also joined. Can you, Prasanna, can you just check any questions on YouTube if they are there? And we'll first of all start off with
a lot of questions on Zoom, Karan.
Yeah, let's take them up first. Okay.
One question from Dr. Akanksha Sinha. For running suture, first bite is radial and the next two is angled to make an isosceles triangle. Is that the way is what Dr. Akanksha is asking, sir?
No, even the first bite that you take is angulated only. You don't take radial. But you can actually start from the surface also. You don't have to take it from within the wound. I take it from within the wound so that my knot gets buried when I'm finally tightening. If I take it from the surface, you can do that. Only thing is at the end, you have to rotate the suture so that the knot gets buried. So that takes, in that process, sometimes you might even break the suture. So I think one thing is important that you can always look at, why don't you draw the sutures, go and take a pen or a paper and on the draw a diagram of that and then look at, if you physically draw the suturing, you will understand how the suture should look in the cornea. So that way it helps. So you have to mentally then follow that pattern when you're doing your suturing in the cornea.
So we have a question from Dr. Aditya Pradhan. So any special tips for suturing in keratoconus patients?
In keratoconus patients, we tend to take the same size of the donor to try and get some flattening. So if you have very advanced keratoconus, sometimes the donor may look a little smaller than what the host bed is. And the gap looks a little more because of the steep cornea is holding up the donor tissue. So keeping the eye a little soft allows you to place sutures easily, and you do get some folds in the posterior layer, especially if you are doing a DALC. In PKP, it doesn't matter because you don't see that. But other than that, I think any eye which is more elastic, where the sclera can tend to collapse, you can always put a Fleringa ring to maintain stability of the eye.
So taking this forward in keratoconus, you can have areas of thinning in the periphery. What is your option like this? Should you do a tuck-in keratoplasty, or what is your approach to such cases?
No, in keratoconus, the sizing of the graft or the donor, basically you would do a regional pachymetry and see. And I think you have to, the size of the trifine is based on where you think the normal cornea is. But if you're talking about cases where there is thinning that goes all the way to the periphery, then you can do a tuck-in where you try to create a peripheral bed, and then your flange of the donor goes into that peripheral pocket that you create and build up the thickness in the periphery.
What is the size
We have a
generally
so
taken in
sorry.
keratoconus cases? The grafts, the donor size?
Usually the trifiniation is about, if you are doing a PKP, anywhere between 8.5, depending on what kind of cone it is. If it's a decentered cone, then either you have to decenter the graft a bit, but then you have to take into account where the visual axis is. And otherwise you can use 8.5 or 8.75. But then, yeah.
Okay.
So we have a question from Dr. Gunjan Buddhiraja. If the sutures and DAL get loose in 1 month, so what is your plan of management?
I go and reapply, but I reapply in between. I don't reapply at the same place the original suture was, because sometimes in patients who have previous history of allergic eye disease, the sutures tend to become loose a little faster, because I think the tear film has more inflammatory cytokines. So there, I think you need to also use steroids a little more compared to the other DAL cases. And if I have that problem, I also keep a bandage contact lens on the eye once I reapply the suture, because I want to minimize the contact of the eyelid margin to the sutures. Sometimes that's at 5 and 7, 8 o'clock, some position where the lid is touching the cornea, that the sutures tend to become loose much faster.
So let's take some questions from the Zoom.
Yeah.
Dr. Akansha again was talking about the Maloney's ring. I think sir has also already answered that it doesn't have a light. You have to use the microscope light. But sir, would you like to do
The principle, how it works is that when you hold the Maloney's ring in front of the eye, the light from the microscope illuminates the steps which are there inside the Maloney's ring. And the reflection, the image of this is formed on the lens of the microscope. And what you see in the cornea is the image that is forming in the lens of the microscope. So it is not something that's going through the Maloney's ring and getting projected onto the cornea. So it's the reflection of the Maloney's on the microscope lens is what you see through the central part. So the cornea is acting like a mirror.
Do you do PI, sir? And is it optional? Do you do in all cases or some cases? That's another question.
I think we were talking about suturing. So
yes, there's a question.
PI,
that's why I took it up.
So PI, yes, we used to do it, and it can still be done in any case where you think there is going to be inflammation, because that can result in pupillary. Basically, you want to. Why do you do a PI? You want, in case the pupil gets stuck to the posterior surface, there is the inflammatory fibrin membrane. You don't want a pupillary block. So that's the reason why you do a PI. If you don't expect any post-op significant inflammation, then I think that PI may not be necessary, or you think that you're going to compress the graft so much that the angle is going to become narrow. Then sometimes you may do a PI just to prevent, any kind of, because of the narrow angle. So maybe if you do very large grafts where, the suturing is near the graft close junction is very close to the, like 10.5, then maybe yes, you can do a PI to avoid any angle closure from the.
Sir, another question from Dr. Chetan Rathod. And how do you gauge the tension of the cardinal sutures? and whether they are too tight or too loose?
Yeah, so I think the first thing you should do is obviously in an open eye, when you're doing a PKP, you can't form the chamber and get the right pressure. So that's why don't apply viscoelastic on the graft surface or don't keep the surface very wet. Because if your surface of the graft remains dry when you are tightening the suture, you can see the tension folds on the graft, So as I mentioned, the first throw is just for approximation. So if you get good approximation, that's the end point. So you don't really need to compress, because what mistake we make when we are doing penetrating keratoplasty sometimes is that we try to, make the sutures very tight, thinking that that's what is giving the water tightness. Yes, the suture need to be of optimal tension, but it should not create too many radial folds, or you should not see like a deep guttering in the center when you have finished your suturing. So after you put your 4 sutures, you can always put an air bubble in the anterior chamber, which kind of, makes the corneal contour come normal. And also the pressure kind of from soft, it becomes like near normal. And then you can dry the surface and see whether it looks like a square or not. If you start seeing, a lot of, or in between the two, if you see a line, that means that particular suture is tight. So you can always remove the tight suture and replace it. So it's important in the cardinal suture that if the sutures are not in the optimal place or optimal tension, always revise that before you put the other sutures. The
So we
first,
have a question from Dr.
first suture is
Sorry,
usually
please.
the suture that needs to be replaced, because when you apply the first suture, the graft is free. So obviously that suture is not the best of sutures that you apply. So when I started off, I used to always leave that suture end long so that I can identify that this is the suture that I have to replace at the end of surgery.
So we have a question from Dr. Kavya Chandran. Sir, your experience of wound leak in continuous versus interrupted suture.
Well, ideally, if you look at that, the apposition in a continuous suture seems to be better compared to interrupted, because of the more number of bites. The only problem is that if the running suture becomes loose faster, then it loses that advantage. There are numerous studies that have looked at the outcomes in terms of astigmatism. While the sutures are in place, running suture seems to provide a better refractive outcome compared to interrupted sutures. And when all the sutures come out, a head-to-head study has not shown any significant advantage between interrupted or a combined or a running suture. Maybe femtosecond laser, the femto PKP or femtodalk, because of the shaped incision, sometimes allows a larger area of graft-host junction, and there we do see a better refractive outcome. But when you do it for cases like keratoconus, if the host bed itself is not having the optimal tensile strength all around, even in those cases, we find that when the sutures are out, you can still have unpredictable astigmatism at times. So there is no perfect suturing technique that can, give you the best refractive outcome. But I think whichever technique you use, whether interrupted, combined, or running, I think if you pay significant attention, you can still achieve a good refractive outcome in majority of your cases.
So there is a question from Dr. Tiger Ceteris saying, in PK, do you still use 90% depth both in donor and recipient cornea when the corneal thickness between donor and recipient varies too much? Need your advice on this situation.
Well, as I mentioned that we try to ensure that the anterior surface is better opposed. The posterior graft-host junction, even if it's little asymmetric, it does not affect the refractive outcome or the surfacing. So you can take a call on that. But usually if you have Optisol or Cornisol stored tissue, you don't see the swelling. The swelling is seen more in MK medium stored tissue, or if the tissues have been in the medium for more than 9 to 10 days, then you can have tissue swelling. So in those kind of scenarios, yes, maybe you can take, you take a judgment call. Sometimes you may take 80-85% instead of 90, but the objective is that the front surface, the bite should be sufficient enough so that the entire graft-host junction Majority of it is well opposed and the surface looks flush.
So, sir, you had said already when you have to replace the sutures, so you put in between. So you would then put two sutures, or would you?
Sometimes, yes, because what happens is in the original site where the suture has become loose, the stroma is already soft. If you go back and try to place a suture there, it will cheese wire very easily. There have been instances, let's say a patient comes back with a loose suture and I see that there is some amount of stromal infiltration or the stroma looks a little cheesy, then I may not do the suturing at the same time. I'll remove the sutures and I'll treat with topical steroids, antibiotic, doxycycline, get the eye to become normal, but then I will go back and place a suture there, because if I did not do that, the wound healing, if it is still not complete, what will happen is that part of the graft will start becoming ectatic. And then later on, when the other sutures are removed, you see a lot of asymmetry.
So, what are the key points for cases? This is a question from Dr. Sunandini. What are the key points for cases of resuturing or in graft host problem cases, or when you suspect there's a graft host junction leak? How do you go about it, even despite when you've done good suturing?
Well, graft host junction leak can happen when your sizing of the graft, that means your donor and graft are the same size, because usually if you oversize it a little bit, that kind of compensates for the gap between the donor and the host. And or when you're excising the host cornea, if you are over if you cut excessively the flange, if you see that and you go with a scissor and you cut out, so you kind of, you have cut out more amount of tissue on the host, and then you put in the graft, you find that the posterior part of the graft is not opposing very well. And then you can have leak from the anterior part. So in those kind of situations, sometimes in certain quadrants, you may have to put more number of sutures rather than just putting the 16 sutures. You can leave an air bubble in the anterior chamber at the end of surgery to provide the tamponade. And I think that's what you would do in that kind of scenario. Yeah.
So in one or two cases, I have seen that from the needle point entry in the host side, you've seen some micro leaks, which I have seen post.
That happens if the host cornea is scarred in that area. Remember that a normal cornea has that elastic property. So when your needle passes through that, the elasticity of the stroma allows it grips the suture, so there is no leak. But if it's a fibrotic cornea or a fibrotic scar, when you pass your needle through that, there is no elasticity of the stroma. So there can be a leak through so you can always, if you're putting interrupted, you can remove your needle and try taking another bite through another part and see to it that there is no leak. Despite that, if there is leak, then I think we have to resort to one of these things of leaving behind an air bubble in the anterior chamber at the end of surgery, which kind of provides tamponade, and usually that settles down and there is no post-operative leak. And if you're going to leave behind an air bubble, depending on the size of the air bubble, either you will have to keep your pupil dilated or you will have to do a small inferior PI just to prevent a pupillary block.
So any tips for pediatric cases?
Pediatric cases, yes, you have to, like I said, that depending on the size of the graft, you can get away by putting lesser number of sutures if the graft diameter is not too large, but you need to see them. The sutures tend to become loose much faster, so you need to schedule frequent EUAs, and the healing is also much more rapid. So you can go and do a suture removal much more earlier whenever the sutures become loose.
Sir, another question from Dr. Nikunj Tank is that how do you manage astigmatism or other refractive errors post all suture removal in long-term follow-ups?
Well, depending on the magnitude of astigmatism, you can, if the astigmatism is less than 5 diopters, corneal thickness is adequate, laser refractive surgery is a good option. You can do a surface ablation, topo-guided laser ablation. If the astigmatism is higher than that, you can use paired incisions like astigmatic keratotomy, either using a diamond knife or the femtosecond laser to try and overcome that. But if you have astigmatism that is more than 9 to 10 diopters, and they look a little asymmetrical on the topography, and you feel that some graft or junction is tight, then we have gone and we have even done revision of the graft-to-host junction. That means the area where it is tight, we open up the graft-to-host junction and reapply the sutures, looking at the reflex with the keratoscope and try to get a. Or if your patient has regular astigmatism and has a cataract, then sometimes doing a cataract surgery, putting in a toric IOL. Or in post-DALK, if you see that kind of astigmatism, it's regular. Even we have done phakic IOLs, toric ICL in such eyes.
Questions on PUK, sir. Suturing when you're doing a smaller graft for that, supposedly. So how would you take? Would you take a full thickness suture?
No, usually you avoid taking full thickness sutures because full thickness sutures would definitely leak, and you don't want a leaky wound where you catch an infection inside the eye.
One more question that Aditi and I were discussing before the thing is about the instruments. So, can you give us some tips for everybody on the instruments, which to buy, which companies, without any financial
I
interest?
think what happens is there are some standard instruments and some instruments which I think you have to get the feel of it. So best is during one of the meetings, you can go to any of the stall because like if you look at a needle holder, you get needle holder with a long handle, you get needle holder with a short. There are some needle holder which have a very fine tip. So I think it's individual preference and your size of your hand and how it feels in your. So you should look at the instrument and grasp it. And then I think you can. Same thing goes with forceps as well. The tooth forceps that you see, you have a straight, you have curved ones, you have angulated ones. So each what maybe works for me may not work for somebody else. So I think and getting a good set of instruments in terms of getting your own the entire set from either from Moria, Catena stores. These are made of very high quality steel and the finishing of the instruments is very good. Especially for me, I feel that if the tang forceps are not great, then it defeats the whole purpose of you trying to place suture of the optimal tension. If you try to, suture and every time your suture is slipping out from your forceps, then either you will end up putting a loose suture or you will, excessively tighten it after repeated, trying 3-4 times. So then it should be something that you can control and it shouldn't be just same thing with your needle holder. The ability to hold your needle should be there. And also, if you look at it, we like using the Ethylon suture. They are very good. The other good alternative to that is the Orolab suture, which I find the needles are very nice. And the third one I can recommend is the Mani suture from Japan. The only problem with these spatulated needles are the needles are very, very sharp and they are prone. They can get very easily blunt or they can bend. So when you pass your needle through the cornea at the opposite end, always push the needle, let it come out a bit, and don't avoid that tendency to hold at the tip of your needle. If you hold with your needle holder at the tip, you will end up bending the tip, or then you will find the subsequent bites, it doesn't go. And this is very important, especially if you start doing running sutures. Because in running suture, what will happen is you're using the same needle, you're passing it so many times. Halfway through, if you find your needle has become blunt, then it becomes a big problem in the sense that then you find that you're struggling to pass the needle, and that's not the optimal way of doing it. Interrupted because it's a double arm suture. If your needle gets blunt, you take the other one and you can go ahead and put your sutures, and every suture is good. So that's where I think handling of the needle is also very important.
Sir, one last question. So that any tips on SSR, selective suture removal? What topography device would you prefer? Or
Any placido-based topography is more than sufficient. What happens is when you just go by refraction, you see the axis, but you don't see on which side of the axis the sutures are tight more. On a topography, sometimes looking at if you have an asymmetric bow tie, then you know the tension is more on one side. So you can first remove the suture on that side and then go and repeat your refraction rather than blindly removing the sutures on both sides. And then, sometimes you may have a overcorrection, whichever is there. So I definitely like to use the topography when I'm doing a suture removal. And don't be in a hurry to remove too many sutures because you think it's a busy practice. You feel, oh, in this, let me remove 3-4 sutures at a time. And then you realize that, sometimes what you could achieve by just removing one suture or two sutures by removing more sutures, it becomes counterproductive.
So,
And practice is the most important, I think, for if you are somebody who does a good number of corneal transplants or PKP every month, then obviously you are in practice suturing that. But if you are somebody who does not do, and you're doing only 1 or 2 cases a month, I think using artificial chamber, getting a donor cornea from the eye bank, doing your trephination and practicing this surgical suturing, once maybe set aside a day, or maybe if you have a OR day, end of your OR list, you say, now I'm going to practice suturing. There is no shame in that to feel that, you have to practice. That makes it better, because you're not worried about the patient, you can take your time, you can do all these combination of whether you want to do double running, whether you want to practice single continuous, all that can be practiced in the donor cornea. And I would say that practice your suturing in a DALC wet lab first, then to open up the graft and do it. Because in a DALC situation, the bed is intact. So what happens is the contour of the cornea is better maintained and you have greater control. So in that kind of scenario, like you do a partial thickness dissection, put in your graft, same graft that you remove, you put it back and try to suture it, the variables are less. So you can just focus on your suturing. Once you get it, then the next thing you do is do a full thickness cut. And then use the same button and try to put it there, because the globe is open, it will take a little bit more control over to do that. Once in the wet lab, you feel that now your suturing is going reasonably well, end of suturing, you look at it and give yourself marks out of 10. And the day you feel, yes, you are scoring more than 7, I think you are ready to go and do it on your patient's eye. But if you straight away go and do it on your patient's eye, I think that's not a great thing to do, because your patient deserves the best. He's come to you in good faith. You can learn, but at the same time, you should be happy looking at the eye next day saying that I've done a great job.
So it was a wonderful lecture, lots of learning, lots of teaching, and I'm sure, like me, all of you have learned a lot from this. A big thank you to Fogla sir. Sir also does a course on PKP, DALC, DSEC, DMEC, Intax, everything. It happens. It's a course or 2-3 day on wet lab. You can get to see live surgeries from sir. I've done this twice, and it has been a tremendous learning experience for me. One of which was in the middle of my fellowship in cornea, and the other was in later on when I was a consultant. So thank you, sir, for that. I would also thank the YOSI Cornea Focus Group and the entire YOSI team for being with us, and Numerotech, who are our the IT team, and that for that. At the other point, I would all welcome you all to attend YOSICon, that is the annual conference of YOSI, which is scheduled at India Habitat Center from 5 to 7 September. We've booked 7 halls. We're expecting a gathering of 1,500 young ophthalmologists to come for this grand event. There will be wet labs, there will be training. If you do want a wet lab on cornea, we can do that also. But the interest has to be there from others. And so thank you again, sir, for being with us despite your busy schedule. Aditi.
Yes.
Thank you so much, sir. We are very grateful to you for joining us today. It was a great lecture, and we still have questions pouring in. But it was truly, thank you so much. So we are truly honored to have you with us.
Thank you. Thank you for giving me the opportunity to be the first speaker for your YOSI session that you do. And
Thank you, sir.
all of you are great surgeons. Whatever I do in my course is I just show you the way, and rest you take it from there. Karan is the best example of that. Sometimes I learn from his video when he shows them. I learn new things, new innovations that he makes. All of you have a wonderful Saturday evening. And if you have any queries, you can always reach out to me. I'm very much accessible and would be happy to answer any of your queries. Thank you. Bye-bye.
Thank you so much, sir. Thank you everyone for joining us. Thank you, Karan. Thank you, whole Cornea Focus team.